Dear colleague, I'm now going to present you a study that was conducted in Iraq on highly drug-resistant bacteria in burn-associated sepsis. Infection remains the leading cause of morbidity and death among burn patients. They are at high risk for infection as a result of the nature of the burn injury itself, the immune-compromising effect of burn, the prolonged hospital stays, the intensive diagnostic and therapeutic procedure. In specialized units of hospital with high infection rate, the spectrum of infective agent varies with time and is specific to hospital. In addition, the control and prevention of nosocomial infection among burn patients present a greater and more difficult approach in low-income and middle-income countries, especially when caused by drug-resistant bacteria pathogen. In burn patients with sepsis, blood culture is considered to be the gold standard diagnostic test among other bacteriology techniques. However, due to limited resources related to the ongoing conflict situation, it was extremely difficult for Iraqi Ministry of Health to provide quality laboratory, infection management, and adequate antibiotics to burn patients. Médecins Sans Frontières supported the regional referral burn center belonging to the Ministry of Health in Suleimania, one of the main cities of Kurdistan in Iraq, from 2007 to 2009. As part of the medical setup, an on-site clinical microbiology laboratory was established in order to adapt antibiotic therapy to local bacteria susceptibility. In the study I'm going to present to you now, there are two objectives. The first one is to describe the etiology of bacterial causing sepsis in burn patients, and the second one is to describe the proportion of multi-drug resistance organisms from sepsis burn patients. We define those objectives in order to adapt antibiotic protocol in burn units. To reach those objectives, we perform a retrospective descriptive study using laboratory database of the MSF Burn Center. Data covers the period from July 2008 to September 2009. Our target population was burn patients with documented sepsis from different inpatient departments, two intensive care units for adults and children, 2 recovery wards for women and men. Documented sepsis was defined by 1 or more positive blood culture. Standard microbiology techniques were used to process blood for culture, identification, and antibiotic susceptibility testing of the isolates. Finally, bacteria etiology with their resistance profile were evaluated using a software called Ronat, created by the World Health Organization as a tool for antimicrobial resistance surveillance. For this study, multi-drug resistance were defined as any of the following. For Enterobacteriaceae, any isolate with ESBL producing strain. For Pseudomonas aeruginosa and Acinetobacter baumannii, isolate non-susceptible to at least 1 agent and more than 3 antimicrobial categories. For Staphylococcus species, multi-drug resistance was defined with methicillin-resistant strain. And to conduct this study, no ethical approval was requested as it was an analysis of routine data. However, permission was granted from the Regional Department of Health. As shown in this table, 65 patients were included in the analysis. The median age was 23 years. Among this population, 78% were women. Most of the patients with sepsis were found in the adult burn unit, where most severe cases were treated. The average positive blood culture per person was 1.5. In that table, we present the general bacterial etiology of blood culture. As you can see, gram-negative organisms represent 63% of all the isolates. The most common one is Pseudomonas aeruginosa, representing 1/3 of them. The less isolate is Enterobacter cloacae with 5 strains. Gram-positive bacteria represent 37% of isolate, with Staphylococcus aureus being the second most individual organism with 17 isolates. This table indicates that 73% of the patients were found to have a multi-drug resistant organism, 63.4% of gram-negative bacteria, and 92% of gram-positive were multi-drug resistant. Among non-fermented gram-negative isolate, multi-drug resistance characterized 2/3 of Pseudomonas aeruginosa and Acinetobacter baumannii. For cocci gram-positive, methicillin-resistant staphylococci represent all the isolates of Staphylococcus species and aureus. Regarding the resistance profile for gram-negative bacteria, the most reliable active antibiotics against Klebsiella pneumoniae were imipenem with no resistance, as well as cotrimoxazole and cefepime with 50% of resistance. For Enterobacter cloacae, imipenem is active on all isolates. Amikacin and ciprofloxacin still work on 70%. For Pseudomonas aeruginosa and Acinetobacter, the old reintroduced colistin was the only drug efficient on all the isolates. Nonetheless, some other drugs were quite effective, like imipenem for both, amikacin for Pseudomonas, and ampicillin sulbactam for Acinetobacter. For gram-positive bacteria, most active agents were clindamycin, minocycline, quinapristine, dalfopristin, and vancomycin. They are all from the last line of antibiotics. We described before that Pseudomonas aeruginosa was the most common pathogen causing sepsis in this burn patient. Staphylococcus aureus being the second as reported in previous study from burn center in Iran and surrounding countries. Acinetobacter baumannii is described as well. This is in contrast, however, with bacteria of burn sepsis from developed countries, which report Staph aureus as the most predominant organism in burn infection, and Acinetobacter being rarely reported. Resulting antibiogram shown in previous table give serious cause of concern. Predominant bacterial isolates were highly resistant to the commonly available antimicrobials, and treatment options for multi-drug resistant strain are very limited. Particularity of our data is the higher prevalence of ESBL producing strain in this study and the one described in previous report from other surrounding countries with available study. In this study, methicillin-resistant Staph aureus has emerged to present the isolates. MRSA, which are non-susceptible to all category of beta-lactam antimicrobial, has become a significant nosocomial pathogen in burn units in developing countries. As this study is only based on laboratory data, we have little information on follow-up, total body surface area burned, delay for admission, delay for referral, and so on. Those information would certainly give an epidemiology overview of the clinical evolution of burn patients in this unit. It also could have helped us to know the rate of nosocomial infection. In burn centers, the most difficult challenge posed by multi-drug resistance associated sepsis were the isolation of organisms that require an introduction of additional expensive parenteral antibiotics, the lack of active oral antibiotics option generally that necessitate a prolonged hospitalization for long-term intravenous antibiotics, the difficulty to have adequate microbiology surveillance based on blood culture or not. Nevertheless, after some time, we were able to set up an infection control committee made up of representatives of each department in the burn center. This committee, that is still active today, was able to promote adequate infection control management strategies. In conclusion, we report a high prevalence of highly drug-resistant organisms among sepsis Iraqi burn patients as a significant problem to treat patients in this burn unit for that specific period of time. However, especially in environments with very limited effective antibiotics, few and expensive options are available to the population. If the complexity and severity of this injury were not enough, the presence of multi-resistant organisms increased the challenge by Médecins Sans Frontières local authority, and those seeking to restore function of the people of Iraq collaterally damaged in these conflicts. With this study, we would like to emphasize the necessity to do further study in developing countries and other burn units in order to adapt antibiotic therapy and avoid the promotion of multi-drug resistance bacteria. We would also like to enhance the necessity to consider bacteriology laboratory as part of Médecins Sans Frontières burn unit setup, especially in such microbiology unknown environments, in order to diagnose, survey, and study multi-drug resistance bacteria evolution to provide the best possible care. I would like to take the opportunity to thank my colleague in Iraq, in USA, in France, and their participation to this study and this presentation. Thanks.